Good evening once again. We come to the second session. Your host for the evening, Dr. Sushrut a dental surgeon at STEMRX. Along with me is my good friend, dear friend, Dr. Premkumar, who is also a dental surgeon and implantologist and has been around for more than 2 decades. And we're proud to have him as our colleague and a friend on the panel, a surgeon on the panel. So we start the evening again with implants. What is an implant? An implant is basically a foreign structure or a fixture placed within your body with the intention of replacing a lost tissue or an organ, which is also capable of restoring the form and the function. And so various type of implants basically, uh, some used for cosmetic purposes like the breast implants, other functional implants like your hip joint, knee joint, uh, whether it is a blade and a screw implant to repair a fracture or a joint replacement as shown here. There are some implants in the heart, cardiac implants, your pacemakers, valves, stents, etc. So basically, a structure placed within your body to replace lost form and function is an implant. So what is a dental implant? Dental implant is a fixture inserted into the jaws to replace the missing teeth along with their form and function. And dental implantology is a branch of dentistry dedicated to dental implants. It is concerned as a replacement for fixed replacement and a permanent replacement for missing natural teeth. A little bit of dental implant history. Father of modern implant dentistry, Dr. Brannemark, a professor from University of Gothenburg, Sweden. He discovered implants by inserting some titanium fibula of the rabbits, and what was noted that they adapted well to the bone, firmly anchored themselves and couldn't be moved. So later on, this concept came to be known as the concept of osseointegration, and it has ever since been respected and regarded as the very ethos of the art and science of dental implantology. A little difference that I would like to show you here is a picture where if you split the image, then a half of it shows what is an implant and the other half shows what is a tooth. Around the tooth, you have got supporting tissue. There is gum, there is bone. The implant also, there is supporting tissue, there is bone, and there is gum. However, what is missing here is, you see these small tiny fibers here. Now, these are periodontal ligament fibers and gingival fibers. In the attached gingiva here is the gingival fiber. Beyond that are all are the periodontal fibers. So here it is the fiber that is holding the tooth and the bone together. Hence, this is a fibro-osseous integration. This here, you see the interface here, bone metal, metal as an implant and bone. There is no fibers here. So here here we will want to call is osseointegration. Should there have been any soft tissue growth here in between the bone surface and the implant surface, then it would be considered as a failure of the implant. A reason why there is no proprioception in a tooth replaced by implant as against the natural tooth. So we have various type of implants that can be used in your jaws. There are subperiosteal implants, there are transosteal implants, there are endosseous implants, blades and frames. What they are, I will explain to you as we go further. So if you see here at the graphic animation, the endosteal implant is going into the ostium, that is into the bone. A subperiosteal is lying above the bone. However, it is put below the periosteum of the bone. And whereas a transosteal implant is something which goes through and through. It comes in two components, and it is screwed below by the base plate there. So subperiosteal implants, as I said earlier, are placed onto the bone, but below the periosteum. Now, what is periosteum? Periosteum is a thin membrane covering the bone, which lies below the gums. So technically, you have to raise a flap, go to the bone, place the implant framework there, and come out. This is a fitting of the subperiosteal implant on a model. These subperiosteal implants are custom made to the individual and need to be fabricated into the lab. This is a radiographic image showing the placement of the subperiosteal implant, and the small parts that you see jutting out here, the small balls that you see jutting out here, basically are to form a ball and a ball and a socket joint connecting the denture base to the implant framework. So these being the balls, the sockets of these balls would be placed within the denture base. That's a subperiosteal implant. We would do this where there is inadequate of bone to put an endosseous implant, and where there is a big framework in design. A transosteal implant again will depend on the available bone and its bone width, and basically this is something which is going to go through and through the bone and lock itself on either side to support the prosthetic or the superstructure that is intended on its way. Here is a radiograph of the same, of the graphical representation. Note that in the X-ray where you see there is remarkable amount of bone loss, and hence conventional placement of endogenous implants is not possible. Endosseous implants, also known as root form implants, endosseous because they are within the ostium. You will, as you will note here, again, just like the natural tooth, our unit here has a root and a crown, which means the root and the crown together by themselves form a functional unit. If this tooth was to be replaced, if this missing tooth here was to be replaced with a fixed partial denture, or chosen to be replaced without an implant, with a bridge, then in a bridge it is only the crown part which would exist, and which would have to be supported by two caps on either of the adjacent teeth. So not this would amount to an unnecessary loss of tooth structure, which is not required, which is not indicated, which is, I don't know, was once upon a time. But today, as we move more towards preservation and conservation together, an implant would be a treatment of choice where there is a crown and there is a root, and it is one functional unit. The bone doesn't get compromised, the adjacent teeth don't get compromised, so on and so forth. This is a radiographic picture showing some implants. Now it is on these implants that we will add a superstructure here, over here, okay, which is known as abutment, and this abutment is going to connect the crown part of the tooth, which is going to be in intraoral function, to the implant. What you see here is implants placed. This picture should be well after the gingival collar has formed around the healing abutment, Uh, so for those who are doctors here, this is an internal hex design, while this is a external hex design. After the surgical phase comes the restorative phase, generally 3 to 4 months in a normal, healthy individual without any medical compromises in the lower jaw, and 4 to 6 months for the upper jaw. After the implant has integrated and the healing abutment has been placed, and then the final abutment is placed, and the prosthesis is delivered. A situation showing us immediate implant placement following an extraction. Some cases, this is we do this out of choice, wherein the implant is placed directly into the extraction socket, and well, bone grows on it, around it, and it all integrates together. This would reduce the healing time, wherein otherwise you would have to wait for the socket to heal and then create a fresh osteotomy, and then wait for the osteotomy to heal again to load the implant. Hence, when you place the implant in a extraction socket and it all heals well together, it saves you on a valuable time. So two concepts: immediate loading versus the progressive loading. Progressive loading, as you see, and as I mentioned, 3 to 4 months in the mandible, that is the lower jaw, and 4 to 6 months in the upper jaw. This is some armamentarium that you see. A physio dispenser here, which is a must while doing implantology. And this is the surgical kit, basically with various hex drivers and drill bits over here. Some osteotomes here for wherein you need to compact bone to gain bone width. Dr. Prem, my friend, will take on from here as far as the indications, contraindications, and a few other things are concerned. So welcome, Dr. Prem. Over to you.
Thank you, dear friend. I welcome again, dear colleagues. And here I'm talking about the indications. Where do we require this dental implants? Wherein patient is having a missing tooth structure. So it could be single, it could be multiple, it could be completely edentulous as well. So you see the diagrammatic images here, wherein a single tooth is missing, there is two teeth are missing, there are two teeth are missing, and they're connecting with two implants. In ideal situation, here there should be three implants, not two implants and connecting the bridge. That is the ideal way, but like considering the economical status of the patient, so we can also opt this treatment modality. And the third is wherein you have no teeth at all in the jawbone, wherein you make all on four implants or six implants or eight implants, where you connect all of them and you make a complete final processes with that. Okay. So where implant indication, as I said, it is used more than more than one single tooth missing or complete edentulous area. You should not be placing implants in a jawbone wherein patient is below 18 years. They need to attend their they need to be the jawbone growth has to be arrested. Then after that. Because under the 18 years, there will be still in a growth of mandible and maxilla, so they are not the condition wherein you can think of implant because there is jaw is not completely arrested with the growth. And upper limit, I mean, you can in any healthy individual, even if it is 90 plus age, you can place an implant. There is no contraindication as such, provided all his fitness and the medical condition provides you to place an implant in his jawbone. Next slide. Yeah. Contraindication, this is very important, dear colleagues, because this is where we need to understand where not to go. Where to go is easy, where not to go is very complicated, because we don't know where we go, and we end up having a lot of complications, and end up having no answers for those complications to the patient. So we should not end up these kind of situations. So where are the contraindications here? So contraindication, wherein patient is a severe smoker, smoker in the sense, like, is maybe smoking 40 to 50 cigarettes a day, and a drug abuser, they are not the patient for you for the implants. Severe alcoholic patients, and metabolic disorder due to severe alcoholic. There is a metabolic disorders, systemic disorder like cirrhosis of liver, and also psychosomatic patients where, like, the psychologically they are disturbed. They are not implant patient for you. And also secondary osteoporotic disorders. See, in you have to understand wherein uh, primary osteoporosis and secondary osteoporosis. What is primary osteoporosis? Any female patient have reached a menopausal age wherein they consider to be a primary osteoporotic patients. So where in that kind of situation you need to load the implant in 1 sigma, that is 5.5 months. That whether a material, whether it is a maxilla or a mandible, you need to wait till 5.5 months. So that's where it is complete, osseointegration completes. So that 1 sigma has a bone turnover, wherein you have a bone maturation cells around the implant. So that is where it is called 1 sigma. There you need to load the implant. You do not load the implant before 5.5 months in primary osteoporotic patients. They are like, they are ladies with a menopausal situation. Whereas secondary osteoporotic, this is a systemic disorder. They are not a patient for dental implants, because they are not going to heal, they are not going to integrate with the implants. And also patient who are undergone a radiation therapy, like, patient who are under the cancer or malignancy, where taken a radiation therapy for a jawbone. They're not your patient for at least 3 to 5 years. Once you have once you're confirmed with their vascularity in the jawbone after the radiation therapy, then certain tests need to be done, and thereafter that you can consider as your dental implant patients. And also, if the patient were they have to be medically fit. If they are under chemotherapy or radiation therapy, they're not your patient, they are the contraindicated patients. And also recently they've undergone any cardiac issues like angioplasty, they're also prescribed with anticoagulants and also blood thinners. They're not your patient for the surgery, because they will have profuse bleeding while doing the surgery, and at the same time you will not be in a position wherein you can stop the anticoagulants or blood thinners. And also patients who are taking bisphosphonates, they are not going to be integrating with your implants. They are the contraindicating patients. And also certain severe metabolic disorders like diabetes and uncontrolled diabetes, and some of these patients who have severe high cholesterol, blood pressure. These are the considerable disorders that you need to consider before you taking the patient for the dental. So let's come to the do's and don'ts of implantology, where what you should be doing, and what you should not be doing. Let's assume a thing wherein there is a patient walks into your operatory area. You need to first check with the thorough medical history. You need to take patient medical history is very, very important. Do not overlook this, because there are certain condition or a medical history a patient might forget or intentionally might forget, but you need to know complete thorough medical history of the patient. Without knowing that, placing an implant it can be a disaster for your practice. So do not go ahead with that kind of a situation. Now, medical history in the sense, you need to analyze complete medical history. What patient is recently hospitalized, or is got undergone any kind of a medical surgeries, or is got any kind of medical disorders, or is got any kind of a recent accident which is led to any kind of complications. These are the medical questions that you need to take the history of the patient. And then after that, you need to take the patient oral examination, take the patient to your dental chair for the next oral examination. In oral examination, do a thorough oral examination checkup, like soft tissue, hard tissue. Is there any caries teeth? Is there any periodontal condition? Is there any ulcers? Is there any precancerous conditions which you notice? These are the thorough examinations that you need to do it for the oral cavity. And thereafter that, you need to I would recommend, like, these are the five key factors which I always follow in my practice. First, I take the medical questionnaire. Then I take the patient to thorough oral examination. After the oral examination, I take the photograph of intraoral, which should be anterior view and the lateral view and a left lateral view, an occlusal view and the mandibular occlusal view. These are for my documentation I take, so that, in case if patient is not there in front of me, if I have to analyze the case, so I have all the documents with me, like photographs. I need to take the study model, that is final impressions of the patient before the patient leaves my operating area for the next appointment for the implant. So I make an impression study model, I articulate them, I check with their articulation occlusion, how they're occluding with a missing tooth or a completely edentulous area. How, I need to check with their jaw relations as well, how they're correlating with maxilla to mandible. These are the medical question. I mean, after the mastercast, you send the patient for the medical investigation, blood investigations. So in blood investigations and photograph and for the radiograph. So these are the five key things which I always follow in my practice. That is medical questionnaire, thereafter that intraoral thorough examination, and then intraoral photograph, and then study model, and then blood investigations, and finally radiograph. These are the key six things which I have in my complete investigations. Once these are all approved from myself, and then I take the patient to my operating area. So these are the five key things. Again, I'll repeat, dear colleagues, because this is a very important factor. First, number one is medical questionnaire, thorough medical examination. Again, take the photographs. Again, take the study model and send the patient for the blood investigation and take the radiograph. These are very key factor which is you need to remember. Once a radiograph is, like, it could be CBCT, it could be OPG, it could be CT scan, any of this radiograph, because you need to evaluate the bone condition. So bone condition, you will be able to make out the thorough CBCT or a CT scan. What is the bone condition we need to analyze? This is bone condition in the sense, like, according to the classification of Manuel Professor Manuel Chanamas, he has classified bone condition into category A, category B, category C, and category N. What is category A, B, C, and N? Category A means you have an adequate amount of alveolar bone on the basal bone in every condition, like mesiodistal width, buccolingual width, and as well as a height, adequate amount of height, wherein you will be able to place your desired length of implant without any kind of exposure or a damage to the bone. So you have your complete implant is within the confine of the dental alveolar bone. So category B is wherein you have an inadequate width. So that is buccolingual width is inadequate. You have an height, you have a mesiodistal height, but you don't have a buccolingual width. So in that condition, what we do? So that comes in advanced implantology. Since we are talking only in a basic implantology, we will be soon talking to you about advanced implantology as well as a complex implantology. There we're going to discuss how do we handle these kind of a situation, like category B and category C and category N implants, because these are advanced surgeries. We handle them with this GBR system or bone augmentation system, that is advanced technology. Very soon we will be talking to you about all these technology techniques. Okay. And what is category C? Category C is wherein you have inadequate height, inadequate width. Category N is wherein complete loss of alveolar bone. There is no alveolar bone. There, my friend Dr. Lima had shown me transosteal implant, frame implant, blade implant. Those are the implants wherein you choose to go with the category N implant, because N situation, because there is no alveolar bone at all. You have only basal bone. So even then, you can still give an implant, but there are various treatment modalities in those kind of situation or those kind of cases. Since again I'm talking to you again about the basic implantology. Again, I'll come back to basic implantology. So now, once you are done with your radiographic evaluation, you measure the radiographic evaluation, and you come to the desired length of the implant, and then you go with the implant. And then after that, there you mention, what is the. Then you come to the conclusion wherein what kind of a desired length and the width of the implant has to be done. And before you once you're done with your radiological analysis and the clinical analysis, now you're taking your patient to the uh, OT. Now let's come to the surgical session. Now before you start the surgical session, thorough scrubbing, you must know this thorough scrubbing, that all comes in asepsis part. Asepsis part, you need to scrub yourself. You need to disinfect all your dental chair or a OT chair, and all your armamentarium, everything. It has to be completely. It is a asepsis is uneven. It is a it is a even full chain of series wherein you don't break the chain of asepsis sterilization protocol, because we need to take care of this, because if you have any septic zone there, like you end up having a complication or a failure of implant. So we would not advise you to go with this kind of situation. The sterilization protocol is the key factor for your success of your implantology. Next comes a skill of a surgeon. Skill of a chief surgeon is very, very important. It is not just placing an implant. You need to know the anatomical structure, the vital structure around the alveolar bone or a jawbone. What are the vital structures you have in the maxilla? What are the vital structures you have in mandible? Because you need to understand, just below your jawbone there are certain vital structure in the submandibular fossa, sublingual fossa, and as well as maxillary sinus, inferior nerve, and the nasal floor. These are the vital structures. You must know what is the speed which you have in your motor, and what is the angulation, what is the control on your speed. So these are the important skill that a surgeon should have. And next, coming to after placing the implant and you give a processes, you must educate your patients. You must motivate your patient to keep the best of the best oral hygiene, because patient doesn't understand. Once you give a teeth, they think they've got everything on this earth. They start eating everything, and people who are left the habit of tobacco chewing or drug abusing, they might start. But you need to keep visiting. The patient should visit you oftenly every 6 months. You need to check with them, check is there any habits which have started, or take the radiograph, check with the thorough examination, motivate them to keep the best of the best oral hygiene, so that you have a long term predictability for your implant or long term success for your implant. And also, you need to have a periodic checkup by taking a radiograph. It could be CBCT or a panoramic radiograph. Okay, and also you need to, in the market now you have any number of implants who have come in the market. You always need to check with what kind of a grade of implant is this. There can be grade 1, there can be grade 2, grade 3, grade 4, and grade 5. What is the meaning of grade? That means it is a pure form of titanium. So these titanium also mixed with some other alloys like hydrogen, iron, carbon. These are the different types of alloys which they have. So you need to understand, grade 5 is the pure form of a titanium, wherein there can be some gaseous product like carbon, hydrogen, but that is okay. But nobody can provide you in the market as a pure form of grade 5 uh, titanium. Okay, so you need to choose your implant by looking at the grade and the design and compatibility. What is the surgical armamentarium which can make you easily user friendly. These are the factors that you need to consider before you buy any kind of dental implant system. Okay, so now let's have a comprehensive assessment of a patient. We have done with this slide. Can we? Yeah, okay. So we are talking about the case selection. So as I said, see, look at this case where we placed a category A bone implant, wherein adequate amount of mesodistal width, adequate amount of height, and also prosthetic envelope where there is no supra eruption, or there is no migration mesial distal of the adjacent tooth. So these are the things that you need to check with the panoramic radiograph, as well as I mentioned. the articulator where you put your maxilla and mandible cast together on the articulator. You need to check is there any migration of adjacent tooth, and also look at the density of a bone, that is D1, D2 according to Colmish. It is a classification of D1, D2, D3, and D4. He has classified according to the density of the bone. Density of the bone in the sense the maxillary alveolar bone has a different density, mandibular alveolar bone has a different density. So when you are drilling protocol, gives you an idea what kind of alveolar bone it could be. It could be D1 to D4. So based on that, you change your drilling protocol. If it is a really dense bone, you need to go with a 1000 to 1200 RPM in a fissure dispenser. If it is too soft bone, you need to go with 800 to 900, yeah, 1000 RPM for the maxilla. For especially maxilla has a very it is a cancellous bone, whereas in mandible it is a dense cortical bone. So mandible always when you're drilling protocol should be 1000 to 1200 RPM, whereas in maxilla it should be 800 to 1000 RPM. It should be okay. So next slide. Can you change the next slide, Dr. Sushrut? Okay, so let's look at some of the cases. These are some of these advanced implantology which we have done. This is the age patient of 61 years old lady, um, well-built health, and there is no medical conditions. Absolutely healthy individual, and we went ahead because she's completely edentulous, and we can see the images wherein like with the extracted socket which are already periodontal compromised tooth. We extracted them and we placed 8 implants on the upper arch. We placed eight implants in the lower arch, and we gave her immediate temporization. Immediate temporization. We did it with the PMMA processes, wherein it's a resin acrylic, wherein patient doesn't exert too much of a force on the implant. Wherein and also we need to give her teeth so that in 3 months she need to have a good chewing facility so that our metabolism maintains to the optimum level so that the implant integrates in a very good manner. So after that we give her a definitive processes, and this is what does our final smile looks like. All right, so can we have a next case? Look at this case. So we have in India we have a lot of patients who are tobacco chewers, smoking, and a lot of reverse smoking. There are a lot of habits which we have. And look at this case with this completely periodontally compromised case, and we did a complete thorough prophylactic step in the beginning, and we extracted all the teeth, and then we done a proper thorough debridement of all the granulation tissue and a periodontal tissues, and then we thoroughly washed with the gentamicin and metronidazole and 1:1 betadine thorough wash, and we created a complete aseptic zone, and then we placed upper 6 implants and lower 4 implants. Again we gave her immediate temporization. Why we always prefer giving a immediate temporization? Because it is a cross arch stabilization. So wherein you are giving a full arch, you are having a cross arch stabilization. So all your implants are splinted together. So you have a better rate of success in that kind of a situation. So and after 3 months, no, after 3 months, no, we gave her after 5.5 months, we give her a final processes, and this is how she smiles in the final processes. Okay, so this is another case wherein patient had a lot of caries tooth and fractured tooth and broken tooth, and she was unable to chew food, and she was difficulty in her phonetics, and she was very conscious on her smile, and we had to extract it, and we took a step in the anterior zone so that because our buccal bone is very thin, and we evaluated that in a CBCT, we didn't wanted to extract the complete root, and along with that, because once you extract the complete root, then the buccal bone or a bundle bone on the buccal surface, it would collapse. So we didn't wanted to have that kind of a situation. We wanted to have a good sound buccal bone. So we went ahead with the partial extraction therapy. We just removed 95% of a root, and we just kept the only the buccal surface of the root so that it is attached to the periodontal ligament, and we went ahead with the implant placement. and we placed all the implants, and then we gave her a temporization for 5.5 months. And after 5.5 months, we gave her a final processes along with the night guard, because in night guard, because it is a processes of with the implant supported processes. So during the sleep, they might have some kind of a parafunctional habit, which can protected with my night guard. Like, it won't affect my it won't exert unnecessary forces on my implant. So night guard is must when you do an full mouth cases. Can we move on to the next case? Can we move the next slide, Dr. Sushrut? Yeah. This is another case where we opted to go with all-on four, because at the posterior, at the region of inferior alveolar nerve, we didn't have an adequate amount of height. So we took a decision of placing all four implants between the mental foramen to mental foramen, and we tilted the posterior implants to 40 degree, so that my occlusal forces will reach up till 6. Even if it is not reaching, with my AP distance, I can anteroposterior distance, I can reach till 6. Even if I give a 6 to 6 processes, my patient will be able to chew food comfortably. There should not be any issues with that. This is how we have done it in a mandible. And on a maxilla, we have done a direct sinus grafting approach. And because the residual alveolar height available was 4.5 millimeter, we went ahead with the lateral window approach, and we did the sinus grafting. And at the simultaneously with the 4.5 millimeter, we placed implants. And also we placed a healing abutment, so that in second stage surgery, you don't need to again do too much of a morbidity, or second stage surgery again, you don't need to anesthetize the patient and then again give an incision, right? Okay, so the maintenance for a kind of a full mouth or any kind of a processes you have it in your mouth, if it is a removable, advise your patient to remove it, thoroughly clean it, and maintain the good oral hygiene. If it is a fixed processes, let them have interproximal brushes, or thorough proxer brushes, or sometimes you can use, if it is a full mouth cases, you can use water flosser. All the bottom line, what I would like to say is, they need to keep their oral hygiene thorough, neat, and you need to observe, you need to check with their oral hygiene every 6 months, and that is how they will have a better success rate for their processes, or implant processes. Home care hygiene. Again, as I mentioned, avoid using a toothpick. Toothpick is not a solution for implant supported processes. And also, they should regularly use antiseptic mouthwashes, and also they should have a regular cleaning every 6 months. They should come for cleaning, and cleaning should be done with either plastic or a graphite scaler. You should never use a metal scaler, because metal to metal, because titanium is a metal again, you should not be using any kind of a scalar tips. That is contraindicated, because the metal surface starts getting scratch, and then you start having a plaque accumulation over the implant surfaces or the abutment surfaces, that can lead to periimplantitis. So that is contraindicated. Failures, see, this is what you see as a failures, wherein I would say the failure you will see when you're not planned your case thoroughly. Planning of the entire case is very, very important, otherwise you end up here. So I would not recommend this to my colleagues. So I would always recommend you to study the case, thoroughly examine the case. If you find any difficulty, approach any of your mentors or seniors, or expertise who have got a thorough knowledge on the implants. Approach them, take their guidance. Shouldn't be a problem. So you will not have this kind of a failures. Yeah, yeah, Dr. Shushut, go ahead, please. With can you unmute? Can you? You're not audible.
I said
Yeah.
this looks more like a maintenance issue. rather than improper planning.
Can you repeat your question? The audio.
I said, can you hear me?
Yeah, now I can hear you.
I said this looks more like a maintenance issue, like more than anything else, rather anything else.
No, here it is soft tissue.
Why I feel so? Why I
Uh-huh.
feel so? Check the cervical abrasions and the gingival recessions there,
Mm-hmm.
indicating a horizontal method of toothbrushing. And then
Mm-hmm.
you also see some deposits along the gingival margin uh, on the other side. Any questions from the audience, doctors, non-doctors? So basically, when you were talking about the partial extraction therapy, which is the PET, I believe
Right.
this is done in the anterior teeth where we retain the buccal side of the tooth and buccal or the labial side, as one may want to call it. And basically, this gives you a better emergence profile.
It is not necessary it should be for the anterior tooth. You can also do it for posterior tooth. You need to have a proper skill, and up till premolar it is acceptable. And also this is not accepted in some of the European countries. Yes, in US and India, yes, it is acceptable, because some has the debate still on the paper. It is like, you are leaving behind some of the infected or the root stumps. That is like, some legal authorities doesn't give permissions in European countries. And yes, of course, it has a it is almost it has a article which has a high success rate, and there is an article published with the partial extraction therapies. There are a lot of article published. You all can go through that. It is a very good treatment modality when it comes to anterior, so that you don't collapse your buccal bone, so that the bundle bone is intact.
So, Dr. Prem, we have a question here.
Yeah.
Uh, from Mr. Subramaniam,
Okay.
Dr. Subramaniam. Can
Yeah.
you just help me with that? Ah, okay. Yeah. So Mr. Krishnan Subramaniam, are you a doctor, sir? He's asking us you to speak a little bit about the artificial bone fillers.
All right. See now, having said it is a basic implantology. So we were only discussing about category A bone or adequate amount of bone. So whereas artificial bone filler is like, you use them wherein I'll just highlight. I'm not going to go in depth, because it comes in advanced or complex implantology. It is a GBR system, that is a guided bone regeneration system. Uh, Wherein having said, I already mentioned that in category B bone, wherein you have an inadequate amount of bone. So where you put your artificial bone material. Artificial bone could be autogenous, it could be allograft, it could be xenograft, or it could be synthetic graft material. There are so many varieties of bone materials available in the market. Of course, they have indications and contraindications.
So,
Preferably, always autogenous is always preferable, but it can, number one, it can lead to more morbidity, and also you need to have a patient consent. With the permission of patient is okay, then you can take a autogenous graft, or also you can have a allogenous graft, which is
okay,
in India, which is available as a Rocky Mountain graft, that is allograft. You can use that. And also, as you mentioned, fillers.
Doctor.
Fillers means artificial bone filler means, in implantology it can be termed as just to make a bulk. Let's say, like, you need to, it is implantology is just not replacing a missing tooth. It is also a missing anatomical structure around
Basically,
your implants.
basically, 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 to be short and sweet, Mr. Subramaniam, artificial bone fillers or bone grafting can be used where there is inadequate bone. Yeah.
That's
Uh,
right.
then we have a question from Sanyasi. Just a minute here. Yeah, Sanayasir Ali. Uh,
Okay.
we are being asked if an implant be successfully placed in a patient who has a deviated nasal bone due to an accident in the childhood. So, basically, I don't see any problem in placing an implant, even if uh, history of a deviated nasal septum or whatever. Deviated nasal septums can also be corrected surgically. It is a good idea to get it corrected. And yes, an implant can be done in such patients.
See, basically, we are placing an implant in an alveolar bone. So, DNS, deviated nasal septum, has nothing to do with your alveolar bone. We are replacing our structure is limited to alveolar bone and the basal bone. We are not going to go into the nasal bone or a nasal floor. We are not going to go till there. Our limitation is only till the alveolar bone because it's a root form or endosseous implant. Stick to your alveolar bone or a jawbone. That's it. You're not going to go beyond that.
Okay. Where is my techno man gone?
Is there any artificial teeth arrangement for 90?
90 plus years old people to have their food. Is there any latest technology? Madam Vaishali, technologies are ever evolving. We don't know what is going to come tomorrow. Uh, Implantology is a good technology in itself to for such people. Of course, there are certain indications, contraindications, and these will vary from case to case. But yes, we can do it for the 90-year-olds also, and you may please bring them if you have any.
Provided he is physically fit. He should not be a bedridden type of a patient at the age of 90 plus. He should be fit enough to come to a dental setup and get his implant. Yes, that can be possible.
No, doc, we'll go to him and we'll do it bedside. No, I mean it.
It is a bit challengeable. It's a bit challenge to do it for the bedridden patient. They are not a patient to take that kind of a treatment plan or a surgical part of it. It is a little slightly a challenge.
Now the advantage of having implants done with us at StemRx is that we are a hospital. We have a
Yeah,
good
it is a complete setup.
we have a complete setup with modular OTs. We are well equipped with relevant experts in the field of medicine to even conduct a lot of procedures, dental procedures to be specific, even under a general anesthesia. And we do have the pre-operative and the post-operative care also associated along with this. I believe the marketing team can give you more details on the various packages and how to go about it. So, any more questions?
Yeah, she has asked for furthermore how to take impression and more on implant kit. Okay.
That we'll announce soon. We are coming up. We are thinking of coming up with a course in basic implantology.
Yeah.
So, I believe it is Dr. Dipti Sharma who's asking this question. So, ma'am, we'll keep
Yeah.
you posted on further developments and we'll be happy to be associated with you. Thank you. Anyone else? So, to summarize, implants are gathering popularity and enjoying a high degree of success. However, diligent home care and professional care is essential for successful outcome. Dental implants are a transformative solution for patients seeking to restore their smiles and oral health, have a success rate of more than 95%. Why StemRx Smiles? For expertise and qualification for comprehensive services. We are situated in a hospital which gives us which gives us a lot of advantage over a lot of things and a lot of challenges, is that we can manage all sorts of conditions here in a very conducive environment where and we even do a lot of surgeries under general anesthesia.
Basically, the hospital has a complete setup in any kind of situation, any kind of patients, wherein you have in-house OT, in-house hospital, everything. That is the best facility which we can provide in this atmosphere.
Yeah, so with that, I will call this session to an end. Thank you so much. We'll soon be
Thank
coming
you
up
so much, dear colleagues.
in
Thank you so
small
much for your
courses.
patience.
For any further details, you may contact our marketing team.